Dr. Desnik is a very distinguished geneticist who originally practiced in Minnesota for many years, has been in New York. He's been a leader in many areas of genetics, including developing effective therapy for Fabry disease. And he was one of the leaders who assisted Detlef Schindler in his first description of this enigmatic disease. So Bob is looking for the clicker. We'll see if Abby has that. There we go. Very good. So again, we're honored and delighted to have Dr. Desnik here to share his vast experience and expertise in this disorder. Bob, welcome and thank you.
So I want to say that I'm very delighted to be here because this group of diseases really needs a lot of attention from all aspects, from newborn screening, from companies developing therapies, and even more important for academic investigators to get a hook into a disease in which they can take some pride of having developed an effective therapy. The major problem is, of course, how do you get to the brain? And we just heard work that's been done in MPS 1 and 2 that's been very successful. And I think this has great application widely. So I'm not working with the company. I'm not doing anything related, but that work deserves its emulation by others. Now, let me just back up for a second. I think about 60 years ago, in 1965, when I was an MD PhD candidate at the University of Minnesota, having had two grandmothers born in Minneapolis, which was a long time ago in the 1880s, I can tell you that we had a great opportunity to really go after therapy. And one of the early things that was going on here and at the NIH was an emphasis on developing treatment for diseases that didn't have a neurologic component. So Gaucher and Fabry were the first enzyme replacement therapies, and then it set off a whole host of other work. But today we're really focused on being, if we can, effectively deliver to the brain. And I think people have tried gene therapy and done other things. I think that's the future. But I want to comment on that after I tell you about the ultra rare Schindler disease. So this is a disease that is secondary to the accumulation of, here we have the metabolic defect, if I can make it work. I'm aiming it right. Help me out. Okay, we're going to talk about the defect, the diagnostic urinary glycopeptides. I'm going to show you the phenotypic subtypes and their clinical features. We made a knockout mouse, but we've never really used it properly. It would be the way to go. And finally, I'll comment on some of the patient and family perspectives. Next, please. Here's the defect. Fabry disease is alpha-galactosidase A. And in my lab, we knew there was a B. So we cloned it, we purified the protein, we cloned it, and it was waiting for disease. And then Schindler reported that there was an alpha-gal B disorder, and I named it Schindler disease. He hated that. But at any rate, I also named Sandoff disease, and he loved that. So, you know, at any rate, what happens in this disease is you end up accumulating alpha-galmac, glycopeptide, glycolipid, glycoproteins. And that is the basis of the disease. Easy to detect on urinary glycopeptides. You can see I've kind of marked them off. There's the pedigree, the two affected boys in this family, and the heterozygotes. You can almost pick up the heterozygotes. These are the urinary structures that we characterized. Glycopeptides, oligosaccharides, and a glycosphingolipid. It's mainly blood group B. A and so, that's it accumulates there. And when we looked at the biopsies, you could see the accumulated material. You could see the foamy lysosomal inclusions that were easy to document. So we identified the first family and reported it in the New England Journal. And it had infantile onset, severe neuropathy, developmental delay, and then retrogression. And retrogression is a sign of all these disorders. They had grand mal seizures, myoclonic jerk, spasticity, et cetera, and it was a nasty disorder. And here's the two young men. You can see them at a year, 3 years, and 5 years. This is a German family that Schindler had seen in Würzburg in his clinic. And the pathology was shown here. And then we started screening broadly for this disease and picked up a second phenotype. And it was in Japan that Kanzaki, who was a dermatologist, was looking at a patient with angiokeratoma. And bingo, it wasn't Fabry, it was a female. And what he discovered was Schindler type 2. And it is a disorder that presents with the skin lesion. They had a mild neuropathy. This lady had an IQ that was, just below average. She was totally functional, but variable symptoms. She claimed she had some pain crises, she did have a facial appearance, a coarseness to her physique, to her facial presentation, and she had the other kinds of things that you see in lysosomal diseases. Here she is, and you can appreciate the angiokeratoma. I went to Japan and saw this lady, and of course, Dr. Kanzaki called it Kanzaki disease. We called it Schindler type 2. At any rate, it got published. We published together. We characterized it, and it was a very important finding. I don't think there's been another case described in the literature of Kanzaki type 2. And then, if you read the literature, there are about a dozen patients that when I said ultra rare, I meant it. We don't know anymore. Maybe in the US, I've been referred a couple of patients that were picked up, had angiokeratoma, and ended up being diagnosed. But that was it. And here's the variable onset of type 3. So there's a disease spectrum, and you go from a neuroaxonal dystrophy of infancy to a type 2 in adulthood. She presented it at about age 25 with angiokeratoma. And then there's this whole group that we call type 3. And I don't know if they're real or not, because if they had some kind of disorder and they got tested for alpha-gal B, they might have gotten picked up because they had benign mutations. We really don't know. We've expressed all the mutations and we characterized them, and all the mutations do decrease the enzyme activity. Here are the mutations that have been identified in the type 1, the type 2, and the type 3, and they've been characterized structurally as well as metabolically. And in COS cells, when you express them, they all have decreased enzyme activity. Here you can see some of the structures that were done, etc. And at this point, Schindler came to my lab and he spent 2 years there. And we made knockout mice. And these mice, as you can see, they they're mixed here with the normal mice, but they had significant accumulation in their brain of the material. Here you can see some of the studies of the storage. And in summary, just to bring this to a head, because I want to make some other comments, we were able to identify this disease. There have been a few other cases, but it's ultra, ultra rare. And even amongst the studies in man, the underlying biochemical basis is similar, and they all result from destabilizing mutations in the same gene. The mice that we've made, it's an opportunity for someone to pick this up and take it another step, but we'll see. They have no enzymatic activity. They appear normal and they survive to adulthood, but they have marked lysosomal storage, both visceral and neural tissues, and they have the characteristic neuronal axonal dystrophy that the type 1 patients had. So what about the future? Well, the mouse model is a future. You could characterize the disease pathogenesis. You could investigate the role of the alpha-gal B in neural axonal transport. You could try and knock in mice with specific mutations and see if you can get the different subtypes. And of course, you could begin to do therapy. So we'll pick this up in a moment, but you know, what's been happening in metabolic disease today, and I'm sure here at Minnesota, as well as in my department at Mount Sinai, we have at least 35 clinical trials ongoing all the time. Metabolic disease, genetic disorders. They are all sponsored trials, but there are some rare diseases, and I not only work in lysosomal diseases, I also work in a group called the inborn heirs of heme biosynthesis. They're called porphyrias. And there's 8 steps in the pathway to go from the basic acetyl-CoA to and glycine and succinyl-CoA to heme. And at each step, there's a different porphyria. Some are more common than others. And for most of them, we developed a treatment in my lab, along with Alnylam, which is an RNAi for 4 of the hepatic porphyrias. There, we ran the clinical trials for alpha-melanocyte, which is a mechanism of tanning people so they're not sun sensitive for the erythropoietic porphyrias. But there are some that are ultra rare. And the one that we're working on right now is called congenital erythropoietic porphyria. It is a good model for what we're talking about here. They have a disease. It's not a neurologic disease. It's a blood disease. And they have terrible sun sensitivity. Trauma will cause all kinds of blistering. So they develop blisters rather than just erythema and edema, which the other more common erythropoietic porphyrias do. To make a long story short, we worked hard on this, and one of our colleagues developed a chaperone which stabilizes the mutant enzymes. Long ago, we learned that in this disease, if you have no enzyme, it's a fetal lethal. It isn't born. The fetus dies at the 4-cell stage. So here they have a little bit of enzyme, and that enzyme is enough to keep them to survive and to be born. The most severe ones will develop non-immune hydrops fetalis and be picked up by ultrasound and then get interuterine transfusions. Most of them are born and require 2 to 3 week transfusions because their hemoglobin drops from, like 12, 13, 14 down to 7. And this chaperone stabilizes, and it's a repurposed drug. And one of my colleagues in Spain that I've worked with developed it. We went to the FDA, and I want to talk about our reception at the FDA because now we're in hematology. We're not in lysosomal diseases. We told them that we wanted to do a clinical trial. They said, first, just prove that your drug, your repurposed drug, which was used to treat some cancers and was a topical agent, they said, prove that you can make it ingestible and that it's non-toxic. We did that in Australia with 17 patients. Took up the dose, reached the maximum. That was it. Those were normal volunteers. We are now working with the FDA, and we've identified a study that they will allow us to do with 6 patients. Ultra rare, 6 patients. You have to have both a PRO, a patient-related outcome. That's what we've been talking about the whole time. You have to have something that the patients say is meaningful to them, a treatment that will be meaningful to the patient. The FDA has gone from accelerated approval, just showing that you can get rid of the pathogenic accumulated substrate, which we all did years ago, to saying, no, you have to have either a combined or a secondary or a primary that says, this is something that will work for the patients, it's something they want. And what we are doing, and so we have that. And what we are doing now is we're having what the FDA allows you to do, and that's to come together and to do a patient-focused drug development program. And what they do is they have 2 sessions. You go to the FDA, and this is the advocacy group that's sponsoring it. And what they want in the first session is 6 patients. And what they ask them is, what's your experience? What happened to you? They're educating the FDA about how terrible the disease is and how it impacted their daily life. That goes on during the first panel. Then after lunch, they have a second panel, which is another 6 patients. What would you expect? What would be meaningful for a treatment benefit? And these are the things you have to do with the FDA. You need to call that meeting together. You need to organize it. We did that with the erythropoietic porphyrias twice, and that drug got approved. And now there's 3 different drugs that are better coming with phase 3 trials. So there's no reason you can't do that. And that's what you need to do. But I want to re-emphasize the point that I made. And that was very simple. You need to be able to know market size. And when I first developed what is now called Fabrazyme, we didn't have a company. I went to the FDA. I had an FDA grant. And by the way, the rare disease FDA gives out grants. We've had 2 now. We've had 1 for porphyria, and we're waiting. We got reviewed for a second one on this rare disease that I'm talking about. And a 4-year trial, 6 patients. I'm hoping that next week, before the 15th, when the government will give back all the money, where FDA will give back all the money to Uncle Sam, which is early because this fiscal period goes to September 30th, but there already is an initiation to have the money sent back early. So if NIH or FDA has all this money that they're sitting on, it goes back to Uncle Sam. You'll never see it. So they're trying to get as many grants as they can funded, and that's what's happening right now in this situation. So I'm hoping that we hear positively, and then we're going to run our clinical trial. If not, we'll have to raise the money, and the clinical trial will probably run $500,000 a year for 4 years for 6 patients. So I just use that as a model of what we've been able to do. The other thing that both Chet and I have done over the last 15 years, he did it with lysosomal diseases, I did it with porphyrias. We had a grant from the government, which is called, from the NIH, which is called the Rare Disease Clinical Research Network Trial Group. And what they wanted was you to collect patients and determine the natural history, because the natural history allows you to predict what will be meaningful to patients in the future and allow you to develop outcome measures that will get approval for a new drug. And that grant was $1 million a year direct. Plus the institution got another whatever the indirect rate was. So I recommend that, but how do we get them to come around to look at a group of ultra rare diseases rather than the ones that they've funded up to now that can get thousands of patients? We need to be able to bring the FDA around to that, because this group of diseases is prime for future. And I think that we really need to be able to get people to recognize that. And I'm hoping that something will happen at World with newborn screening. Something will happen at World where we're talking about developing treatments for ultra rare diseases. So I thank you for your attention, and I think that we'll have Janine give a few pointers on what she can do for Schindler, but I think it's too rare. It's just too rare. Thank you.
Now, Bob, before you escape, we have to make sure you can take any questions. I have one for you, actually, because one of the interesting things from a neurologist point of view is when you look at the phenotypes of the type 1 Schindler disease, they look awfully like neuroaxonal dystrophy plus angiokeratoma. So some years ago, as I'm sure you're very well aware, when Susan Hayflick found the phospholipase A2 mutation in neuroaxonal dystrophy, she said, could it be that that's also present in these type 1 Schindler's patients? So the question is, have they actually been examined to see if they have a mutation in that second gene?
So besides NAGA, the other gene, there's been a paper that you maybe know about that suggests that they're both on the same chromosome, okay, and they're not, but when you look where they are, they're far apart. So we're in the business of sequencing those kids, and we'll clarify it one way or another. Right. Okay.
Thank you very much. Very good. Well, again, we rarely have the opportunity to hear about diseases from someone who was in at the discovery and actually got to name them as well as some others. So that's really a fabulous opportunity. We're very grateful for Dr. Desnik for all that he's done for genetics over the years, but specifically for being here for this meeting.